We will start this wonderful session on innovation, which has been very close to me and a lot of my colleagues out here. And we have a very distinguished panel spanning different specialities. With Dr. Nidhi. She's a cornea surgeon. Special area of his interest is endothelial keratoplasties, training, teaching, imparting the next generation to pick this skill, but also doing a PhD with Singapore. Professor Anant Bandari, head of the department of one of India's top medical colleges, MS Ramaya. Dr. Edwin James, professor in Kollam Medical College. We have Dr. Sushmita Sen Shah, accomplished researcher, and then a very accomplished cornea surgeon. Dr. Dhanashree Ratra ma'am, retina surgeon and from Shankar Netralaya, and we have Dr. Manjunath Marasandra representing the researcher and linking research in private practice. So we have a very accomplished speakers and also very accomplished panel who will take this whole program forward. I'd like to invite Dr. Vineet Ratra, sir, for his talk on macrophage-like cells on retina as early biomarker for glaucoma.
Thank you, Dr. Rohit, for inviting me for this session. So what I would be talking about is macrophage-like cells on the retina. These serve as early biomarkers for glaucoma. Well, I'd like to acknowledge the help of Mr. Satish and Deepika, our optometrists, who helped out with most of the imaging. So we do know that glaucoma is an optic neuropathy. It is characterized by retinal ganglion cell loss with retinal nerve fiber thinning, with neuroretinal rim thinning, and the only treatable risk factor is intraocular pressure. The cause of the retinal ganglion cell loss is multifactorial, and one of them is neuroinflammation. So what are macrophage-like cells or microglia? They are the first line of defense in neurodegeneration. These are the innate immune cells of the retina. They are self-renewing. They are present in all retinal layers. They are the first line of defense, and any insult leads to a microglial activation. In the early stages, it is neuroprotective. However, in later stages, it becomes neurodegenerative. There have been theories on retinal ganglion cell damage, and one of them was the overexpression of the phospholipid scramblase 1 protein when the intraocular pressure rises. This acts on the microglia, causes the release of CD68, TNF2, interleukin 1 beta, and this causes microglial activation, causing a damage to the retinal ganglion cells, which then get either phagocytized or apoptized. If you look at what Block and all have done, they have shown in studies that in patients on Alzheimer's and Parkinsonism, microglial activation and neuronal loss begin as early as 10 to 15 years before the disease manifests clinically. So does this also occur in glaucoma? So we can do a in vivo visualization of the macrophage-like cells with OCTA. And how do we do that? We take retinal images 6x6 over the fovea using a Zeiss Cirrus 6000 machine. Then we segment it 3 microns above the internal limiting membrane. These are then exported into the ImageJ or the Fiji software. These are the method is described by Ong J.K. et al., but we modified it to suit our requirements. So it's a semi-automated protocol. And once all this was done, the MLCs were highlighted with red color and superimposed on the angiographic images for better localization. So this was a pilot study we did to evaluate the macrophage-like cells in glaucoma. Our cross-sectional study compared macrophage-like cells with the structural layers. So we took eyes which were controls early and late glaucoma. The inclusion criteria was patients who were greater than 40 years of age, and who had good OCTA scans with good signal strength. Those with poor scans, media opacities, retinal disorders, diabetes, other neurodegenerative disorders, surgery, or those who were on chronic treatment with neurotoxic drugs were excluded. The glaucoma was classified based on the Huda-Parrish-Anderson criteria into early and advanced. So all patients underwent a comprehensive glaucoma workup, including an OCTA, and we compared the MLCs and structural parameters. There were 100 controls, 118 early glaucoma, and 85 advanced glaucomas. We found that the MLC counts were higher in the early glaucoma as compared to the control, and even higher in the advanced glaucoma. This is how the representative images of the normals, pointer nahi aa raha hai, of the normals of the early glaucoma. Yeah. And this is the advanced glaucoma where the red cells tell you the MLC cells. So we compared them and we found a significant negative correlation between MLCs and ganglion cell complex, the retinal nerve fiber layer, and also the central foveal thickness. So as you can see here that this was the central foveal thickness, GCC, retinal nerve fiber, and you can see that the MLC counts were less in controls, a little more in early glaucoma and higher in advanced glaucoma. There was a strong and significant correlation between the MLC and the structural parameters. So the key results were that MLC activation can be seen in early glaucoma. It shows a significant negative correlation with severity of glaucomatous damage. And this is indicating possible potential as a biomarker for neurodegeneration. However, there was a limitation. We didn't have longitudinal follow-up of these patients. Neurodegeneration severity can be predicted from early microglial alteration monitored in vivo in a mouse model of chronic glaucoma as shown by Bosco et al. There have been treatment targeted to this immune modulation. Should we consider immune modulation along with reducing intraocular pressure? If we could, we get a larger window of neuroprotection. Probably we can do an index and generate further studies. There have been use of monocyte chemoattractant protein 1 in experimental mouse glaucoma. And this is in press, this article which said where they use platelet factor 4 to attenuate the inflammation of microglia. And this protects the retinal ganglion cells in retinal excitotoxicity. They concluded that PF4 may possess neuroprotective properties through simultaneous modulation across multiple cellular pathways in glaucomatous neurodegeneration and emphasized the significance of immune-mediated mechanisms. So to conclude, it's a non-invasive strategy to visualize and monitor the MLCs. Live monitoring can give a unique insight into the pathogenesis. MLC could serve as a biomarker, and we could develop novel approaches to neuroprotect. And this may actually prevent vision loss much earlier than once that we actually glaucoma sets in. Thank you.
Thank you. Can you just play it on a few slides back? So we'll be using it for the. Can you place a few slides back? If you can play the slides again. A few slides back.
आपको पीछे करना पड़ेगा. यहाँ कंट्रोल दे दीजिए. नहीं है. अच्छा.
The slide number 25. So it's very interesting area of work in ophthalmology where many new pathways have been described, and using these pathways a lot of immune modulation can be achieved. There's a work done by, I think Tirumalesh is here. We found some neutrophils in the retinal cells which were causing degenerative changes in age-related macular degeneration, which got published in a very high-impact journal. So we are seeing neutrophils, looking at macrophages, I think what Dhanashree ma'am presented the other day. So that means all this is becoming a more immunomodulation, immuno-driven therapies. So a lot of your drugs today, you working on blocking an anti-VEGF or blocking some pathways, which is the downstream part, but you're not looking at what is happening, which brings it to it. So what is interesting here is that the role of, say, curcumin, the role of DHAs, the role of one of the very important role which we have addressed this kind of a pathway. See, macrophage and dendritic cells are there in your cornea. The dendritic cells are also antigen presenting cells, and the dendritic cells, when it touches the T lymphocytes, they have a handshake where the receptor of a dendritic cell is called the LFA, and the receptor of a T cell is the ICAM, or the other way. So what they do is when they touch each other, you release those cytokines which you mentioned. If there's a slide which you showed, IL-1 beta, TNF.
Yeah, that was before. I'll show you that.
There was one slide which is very interesting slide.
Yes. That was one of the early slides which spoke about this one. Yes.
So you have an antigen presenting cell, you have a T cells come in contact, they need to, they have an handshake and they release those factors, and those factors have an impact in many outcome, non-healing outcomes. So one thing which we should look at is trying to repurpose drugs from the anterior segment to the posterior. For example, one which can help this deactivation of that is lifitegrast or Zedra. And Zedra is used by anterior segment thing, and that blocks all those things which has been secreted. So I think a takeoff from this study would be, how do you actually start looking at modulating this in the posterior segment? The exact mechanism, but only thing is there you have a dendritic cells. Of course, they're all the same antigen presenting cells. They come under the same category. So how do you block it is through this. So you should probably take this work forward in trying to see how we can use that. And this is an ICAM modulator which Tirumlesh is going to speak. I mean, just an insight into from what I learned from your presentation.
I think so. If we were to be
Yes. I just wanted to make a comment. So this is really very exciting study that Vineet has shown that there is an MLC activation, and probably there is an immune basis for glaucoma, and there is a possibility that we can use early neuroprotection, and especially in situations like a normotensive glaucoma or patients with high risk characteristics, you can start neuroprotection much earlier and try to prevent the vision loss. However, the crux here is that the neuroprotection and the inactivation of these microglia is actually a very delicate balance. So what I understand from whatever literature I have searched, so when you are giving these immunomodulating drugs, there is a very fine balance between these MLC deactivation. So if you give it in small quantity, it is a protective, and the MLCs can get deactivated, and it will save it will prevent neurodegeneration. But beyond a certain limit, it can be a detrimental, and you will have in fact more neurodegeneration. So the problem is not in repurposing the drugs or identifying, but it is to identify this thin line between the neuroprotection and neurodegeneration.
Absolutely. So what I would suggest is that if you create the same experimental model where you have created that dendritic with the amount with that, and you use repurposing drugs on them to see if it can actually block, then it will be a good translation.
Yeah, so what was shown was that if you give it in smaller quantities, it is neuroprotective, but if you give it in higher quantities, it becomes
These are all very low quantities,
Yes.
you can even use
Giving
a
anterior will be
Yeah, exactly.
Yeah, I think that makes good sense.
Thank you.
Thank you.
Dr. Ratra, I had the anterior segment in the trabecular meshwork also you have macrophages, which when activated, initially, as you said, mild macrophage activation actually clears the trabecular meshwork. but severe, it actually blocks the trabecular mesocrita. So I think the conditions like dry eye also activates the, you have any thing to say is the dry eye actually exacerbates POAG?
So thank you.
So I was just curious from the clinical point of view. This is regarding those who have a family history of glaucoma. We always keep telling them they need to go for RD screening and things like that. So do you think, would you see a different pattern, or will it help in identifying those with a family history, whether they're going to eventually get clinical glaucoma or at risk?
Yeah, so if they are healthy risk, you could just follow them. But if you have that at risk who you think would go in, probably, we don't know. Too early.
Thank you, sir.
It's a great pleasure to call Dr. Nidhi Gupta, who has extensively worked on endothelial cells, and she's going to speak about endothelial cell therapy in clinics and future of corneal transplantation.
Thank you, Dr. Rohit Shetty, for the invitation. It's completely a pleasure to be in this session. I think I'm going to be learning more than I will be presenting. But my whole concept, or the whole idea of presenting, is not only presenting the endothelial cell therapy, but to encompass all the developments in this field which are going to actually lead to a better management of these patients of the endothelial disorders. So if you look at the development of how the endothelial transplant has developed over years, from the first time it was developed in 1906 to now 2012, where the major development happened, we are only going thinner with the tissue. We are only going lesser with the tissue. And the idea behind going thinner with the tissue was to get this map, is to get better transplants. The transplants wherein DMEC has done better than even DSEC, and that would not only mean being anatomically closer to the treating the disorder, but also to reduce the immunological reactions, to have better graft survivals and better visual outcomes in these patients. But as clinicians sitting here, I'm sure you must be looking for these questions in the talk. And why are we even talking about cell therapy? Are we even diagnosing this disorder better? Is there a better medical management before you jump on to telling us about the surgical management? Is the present technique going to improve? Can the surgical interventions at present become much more simpler? And what's there for me as a clinician when you talk about cell therapy? So I'll be addressing these questions, and my talk would be focused on answering all of these, and I'm happy to take questions towards the ends in detail. So why are we talking about cell therapy? It is because, as cornea surgeons, we know the tissue which is available is far less. You have only one tissue available for 70 patients. So even if you equip all of us with the kind of transplants, make us better surgeons, we can only go beyond a point we cannot reach in treating these patients. So we do need to develop ways in which we can circumvent this issue, we can take up this challenge. But the first important question in clinics is that you are only diagnosing a very small area of the cornea. Corneal endothelial specular microscopy gives you very small central cornea to be diagnosed. So what has come up into clinics is wide field specular microscopy. For now, it is available for researchers, but we will be looking for a future wherein it's available even for clinicians. And what is it going to help is to help you even scan the specular endothelium in the periphery of the cornea. That is going to allow you to diagnose these patients better, manage these patients better. It's because if you have a good peripheral cell count available, you probably are doing the transplants too early, and you could shift on to a better medical management for these patients. To go on from that question to the next question, are you going to have better medical management for these patients? The answer is yes. We are already in clinical trials for a large group of drugs which are Rho kinase inhibitors. We already know that reposudil is available for glaucoma. The last speaker had spoken about glaucoma. And now it has been tested even for corneal disorders. In corneal endothelium, you can either combine it with DSO, which I'll be speaking in my next few slides, wherein the corneal endothelial cells, which are already present in reserve in the periphery, can migrate, adhere better, and also have lesser apoptosis. Other drugs over here, one of the ones which are worth mentioning is sirolimus, which is also in drug trial. Even at LVPI, it is being tried. At the recent World Cornea Congress, they had presented their results and they look encouraging. Let's wait for the long-term outcomes in these patients. But this is the drug for look out for in patients of Fuchs dystrophy, wherein you have a central small edema and you can still go ahead, do a cataract surgery and give rho kinase to these patients. From rho kinase, let's go on to what are the better techniques which are available. From whatever present is available, can we do something better? Yes, as clinicians, we can do better. If you are a lamellar surgeon who treats both anterior and posterior lamellar surgeries, you can actually combine DALC and DMEC in the same patient, in different patients with the same tissue. That is something which I've been doing in my clinics as well. And another thing, which is even recently, we have 5 years outcomes of DSO. DSO is Desmet stripping only. This is a management tool which has come for clinicians, wherein if you have a Fuchs dystrophy with only central edema, which with peripheral cells being very intact in these patients, you can just do a Desmet stripping without any endothelial transplant. And the results in hands of some of the pioneers in this work, which is Catherine Colby, they have shown 5 years outcomes are amazing. They have 75% success rate in these patients with DSO. They have combined these patients with rho kinase inhibitors and they've done well. So this is something which probably is more for the Western population, wherein Fuchs is more prevalent. In India, most of the Fuchs patients even do good without DSO for now. Can the surgical intervention be simpler? Yes. Even the iBank has done something very good with the DMEC, is to give preloaded and pre-stripped DMEC tissue. In India also, pre-stripped DMEC tissue is being provided by LVPI, and that has helped the clinicians to make this surgery better and more predictable. Now let's go on to what's there for clinicians in cell therapy. Cell therapy is not just one therapy. It encompasses a large group of areas. I would be just covering a small area which is now going to be in clinics, and that's the area which I've covered in cell culture. So just to give a small introduction, for these cells to be cultured, you can either take it from the cadaveric cells or from the human embryonic stem cells, or you can take the iPSCs. And these once cultured and multiplied into millions from one cell, you can either inject it or you can grow it on a tissue, which can be a human tissue or a scaffold tissue, and inject it into the eye. Now, what has happened, come into clinics? This was all up till the research, but it was in 2018 with the landmark paper of Professor Kinoshita that we saw that this actually works even in patients. 10 out of 11 of these patients have now 2 years follow-up, and they have done excellent with cell injection therapy, which was printed in this paper. But what is very exciting, which has come up, is that you can actually do a magnetic cell delivery. This is the work from Ellen Koo, which I have taken. She is at Bascom Palmer. They have done work in this area wherein not only that they have grown the cells, they have actually combined it with the magnetic nanoparticles. And the idea behind combining with magnetic nanoparticles is to make sure that these particles, when combined with an external magnetic field in the form of just a magnetic eye patch in these patients, they go and adhere into the endothelium, and there is minimum cell loss in these patients. Now, they have done some clinical trials. I would not be going into detail of it, but to show you one of the results which she had specially sent for this presentation, and I would like to acknowledge her work, is that this is the patient at the baseline of a Fuchs patient, and after 3 months, you can actually see those guttae which has come down in corneal edema resolving. The number of surgical guttae have come down. What has also come down in these patients is the corneal edema. Also, the best-corrected vision has improved, and there is an increase in the ECD of these cells. These have been the first 3-4 patients which they have done in their clinical trial. From the cell culture, there are some limitations, however, where we have such exciting news. We know it needs a specialized laboratory facilities, trained personals, appropriate expertise, good manufacturing practice environment, and there are a lot of regulatory safety standards world over. It is not easy to have a HCH culture lab. And also we know their tumorigenic and immunological rejection risk is high in these. So what is more simple, and this is the work by the Singapore group with whom I'm working, is simple non-cultured endothelial cell injection therapy. It's an amazing concept wherein the repurposing and utilization of the donor cornea deemed unsuitable for transplantation can be injected into the time. I'll take just 2 minutes more. Herein, you can see there's a lot of donor cornea which remains unutilized. These cells can be separated, trypsinized, and injected into the eye without culturing them. And they have shown even age group of 4 to 71 years old cells which have been used, which have shown very amazing morphological analysis, as well as they have shown good results in animal trials. These are the rabbit eyes in which corneal edema has come down in these patients in a period of about 2 to 3 weeks. And they have shown similarity on the confocal microscopy to native cornea as well as the cultured corneal endothelial cells. So the additional advantage of this technique is that it is simple. That's the main point. You do not require a laboratory facilities. It can bypass the stringent regulatory requirements and has a wider applications. So for this, I would just like to summarize my talk by saying that corneal endothelial dysfunction is a major corneal cause of blindness. It is the fourth largest cause of corneal transplantation. It is limited human tissue is available, because of which we need therapies which can overcome these challenges. Human corneal endothelial cultures requires highly specialized infrastructure. However, it has a great potential for good results. What is coming into the therapy is the magnetic cell therapy in clinics, which is in the trial phase, as well as if we can give simple non-cultured endothelial cells into clinics, that is going to be very simple solution for this problem of corneal endothelium. Thank you, and I would like to thank this team with Professor Jod, Gary being there. They are my collaborators, and I've really learned and enjoyed working with them. Thank you, Dr. Shetty.
Dr. Nidhi, amazing presentation as usual. One question is, any experience with working on iPSC cell lines?
Not for now, not for now. But what I have seen is that they are growing the cells on scaffolds,
Yeah.
on human tissue, and that is going to be the future. That is under human trials. They are under human
No,
trials.
Sharon, my colleague, and we have been working on it. We have been able to culture the cells,
Yeah.
but we tried different methods. We
Yeah.
just last 3 days back, she did a rabbit experiment where we injected it, and we are trying to see whether it's actually going. So it's magnetic driven one might have a role.
Yes, yes.
The second question is about the endothelial DVEC, you call it, right?
DVEC.
DVEC.
DSO.
So if you look at the literature, there are some where it's work. People have some cases which works well, some cases which don't work well. Now that you're working on your PhD on the endothelial thing, do you think there are endothelial factors which is in your aqueous, which are
Absolutely.
which will make your cells to heal better or to create more challenges?
It's a very good question
So-
as to whether there are factors in the eye which are going to decide whether the treatment is going to work or not. So if you look at the work from Japan group, Yamaguchi et al., they have shown that there are inflammatory mediators in the aqueous,
Exactly.
and these cytokines have been studied by this group last 4-5 years. If you see their work, they have studied the aqueous cytokines in Fuchs versus PBK versus normal eye, and they found that PBK eyes have these cytokines which cause the apoptosis of the
Absolutely.
cells. That's the
Absolutely.
key. That's why in India, if you see the results in Western versus Eastern, you would have different results and outcomes.
See, if you look at the TGF beta, which is what Dr. Pooja is going to speak now, we did some work on the aqueous. It differs from
Absolutely.
different geographical
Absolutely.
countries, your work,
Yeah.
your systemic health.
Yes.
So and that could be a predictor of looking at whether this will work or not, if you're looking at measuring the TGF beta
Absolutely.
when you're doing that.
Yes.
So I think that's something which you can take it forward
Yeah.
and maybe give us an insight next year with
Thank
your
you.
team. Thank you.
Thank you, Dr. Shetty.
I'd like to call upon Dr. Pooja Kamar. She's going to speak about a very interesting concept of how do you do a corneal modulating the TGF beta pathways in new frontiers in corneal wound healing and scar modulation. Dr. Pooja.
Thank you, and I would like to thank Dr. Rohit and the entire AIOS committee for giving me this opportunity. So as we all know, corneal scars or corneal haze can be like that dreadful complication for any of us to present. And when it comes to managing a corneal scar, it's quite difficult because it's not just one etiology or pathogenesis involved. Your corneal haze or scar can be because of many reasons, which can be PRK, because of chemical injury, keratitis scar, inferior graft edema, many things. So you have to first identify what etiology your scar or haze is because of and then go ahead with it. So usually, whenever there's a normal wound healing response, there is always some amount of TNF-alpha and other inflammatory markers which are involved in a normal wound healing. They activate your keratocytes after any injury or any scar. Those keratocytes gets converted to myofibroblasts, and then this myofibroblasts, they kind of apoptotize because of various markers being generated in the eye, and it kind of dissects your aberrant collagen, and that's what leads to a normal wound healing. These are how your keratocytes look like. You can the less the white the body is, that means lesser activation. This is what will happen after your PRK or any injury, the myofibroblast conversion. They get apoptotized, and that's when the normal wound healing comes. But when this balance of the inflammation and anything is broken, whenever there's a higher amount of TNF-alpha or any inflammation, then that's when it will lead to abnormal wound healing with higher amount of myofibroblast not getting dissected or cut with the genes present in it. That's when it leads to aberrant collagen formation, and that's what leads to formation of haze. I'm trying to simplify it much in a simplified way so that all of us clinicians understand. So let's see this case example. This is a lady who came for refractive surgery. Everything looked fine. The dry examination is normal. The topography showed a corneal thickness of 480 and 475, so it was a little bit on the borderline side, so we decided to go ahead and do a trans-PRK surgery for this patient. However, 6 months post-operatively, this patient developed haze, and this is what the densitometry looked like, more at the 3 and 9 o'clock position, because we had done a cylindrical correction for this patient. And we treated the patient with steroids, immunomodulators, and tacrolimus eye ointment, but the haze did not come down. It was more of a late onset haze. So we decided to go back and look into what were we missing. So we've developed this BioM Pathfinder kit, where in my own clinic or any one of your clinic, you can measure all the biomarkers in just 90 minutes like a hemogram report. You do a tear test with a Schirmer's like how you do it in any normal clinic. And without discarding the Schirmer strip, you collect it in an Eppendorf tube. And then you add a patented buffer solution which comes with it, and then you shake the tube for 5 minutes so that all the proteins gets extracted in the tube. And then at the end of 5 minutes, you take the solution and put it in the cartridge. At the end of 90 minutes, you'll get this report like a hemogram report, where there's a detail of every eye, right and left eye, the level of biomarkers present, the inflammatory, non-inflammatory, whether they are normal and abnormal. And based on that, you can find out whether there's a healthy eye, whether there's subclinical inflammation present, or whether there is inflammation present. And based on that, you can devise a treatment for this patient in a customized way. Now, our patient, we had stored tears for this patient, and our patient had higher levels of TNF-alpha present to begin with. Now, why is TNF-alpha or other inflammatory markers of reason? Whenever the TNF-alpha is on the higher side, it kind of imbalances the healing of any post-surgical procedure or any scar or anything, and there's a lot of pro-inflammatory cascade going on. And whenever there's a lot of pro-inflammatory cascade going on, the TGF-beta molecules goes on the higher side, and that's what leads to haze, and that is what happens in any patient. So you have to take care of TNF-alpha. Now anyone will ask me, TGF-1-beta is normal, right? It has to be present for healing. Yes, TGF-beta is a double-edged sword. Any amount of normal TGF-beta leads to a normal wound healing process, but any amount of higher TNF-alpha leads to higher TGF-beta production, leads to abnormal wound healing, and that's what leads to haze or a scar formation. Now, we have to look at medications. None of this worked on a patient. So for the past few months or years, we've been listening about losartan. Now, what does losartan does? It suppresses the TGF-beta activity, scarring of the wounded corneal stroma with inhibition of extracellular signaling, regulated kinase-mediated signal transduction. Now, what's that? Quite complicated, right? So to simplify it, what losartan does is, losartan tries to start breaking this myofibroblast. Those white bodies which you saw on a confocal, the losartan starts killing them, and that's when it leads to inhibition of fibroblast formation. That's how it starts cutting your scar tissue, and that is what happens. So before doing any studies on patients, we did some cell line studies, and what we saw was that when TGF-beta means there is a scar, whenever you add a losartan on this scar tissue, the scarring starts coming down, which you can see on this alpha SMA and vimectin, and also the collagen which is leading to scar formation also starts coming down. So we used losartan 4 times a day for these patients, and with it's a slow going process, but you can see the haze is coming down, and after a total of 6 months, the haze was finally 10%, it came down by 90%, so the losartan was working. Now, we did do a recorrection for this patient for scar removal, but it didn't help, so we did not have one more choice of doing a recorrection, and that's when we went to losartan eye drops. Now, we have used losartan eye drops for corneal scar patients as well. It's an ongoing work, but you can see with 1 month of treatment how the scar is coming down, and this is also one more patient where you can see the density of it is coming down with just 1 month of treatment. Now we wanted to see what's happening, like what's happening to this scar, and this slide I've borrowed from Dr. Rohit, and my colleague Deepti helped me make it. You can see there's a lot of traction line scenes due to contraction towards the area of fibrosis. So that's what is kind of leading to the hyperopic shift in this patient. And when we started using losartan, not just the scar density reduced the contraction bands towards the area of fibrosis, but when you see this confocal images, you can see there's a highly dense area here, and this is what the myofibroblasts and fibroblasts look like. And when we use losartan, you can see it's cutting down those fibroblastic tissues, and that's how the haze is coming down, and that is what you see. Now, scar formation is not just TGF-beta driven. It can be because of abnormal angiogenesis, keratocyte proliferation, and epigenetic dysregulation or immune cells and factors. And it's not just one therapy which looks like it. We have to look at gene therapy, amniotic membrane therapies, or limbal stem cell transplant as well, and newer topical drops to make it simplified to treat these drugs. So one of the drugs which will help us will be a potential for a ROCK inhibitor to treat the corneal fibrosis, because substance P induces fibrotic changes via the ROCK pathway, and if you use a ROCK inhibitor, it can help us in reducing the fibrosis. We are also looking at SAHA-based drops to reduce the scarring of the corneal tissue, and if nothing works, the future would be towards the gene therapy for treating the corneal fibrosis and angiogenic related changes, where if you use a gene therapy, the scarring does come down, and this is work done on a rabbit model for corneal haze prevention. So as simple as possible, we have to come up with newer drugs to treat haze where nothing works, or your retreatments with surgery also fail. However, the future direction would be a gene therapy or a nanoparticle drug delivery or a bioengineered cornea. So to conclude, traditional therapy does have limitations in effectiveness and potential drawbacks. We have targeted non-invasive therapies which offer scar modulation and less invasiveness, but we can work on it in more numbers, and the next gen regenerative therapies would be promising advanced solution through innovations. Thank you.
Thanks, Pooja. As always, a fantastic talk. It was a very interesting topic when you started to speak about corneal scars, especially post-chemical burns. So I just had a question for you, that when you followed up these patients on, looking for factors in the corneal scarring, what was the longest follow-up in these patients that you take?
Ma'am, we've started using losartan only for 6 months now. And as you have seen in published literature, it's a slow-acting drug. So it just doesn't act right away. It takes 6 months to 1 year with these drops for the scar to come down by 90% or disappear. So the haze patient, we've given it for 6 months with 90% resolution of the scar, and the one for because of the herpetic changes and the post bacterial infection, the second and the third case, it's just 3 months. So it's work in progress.
Yeah, so the only thing which I had, probably it could be in addition to your work, the fantastic work that you're doing, is that when we are looking at these scars, even clinically we see them shrinking over time, and it is only beyond 3 to 6 months that we either post-chemical burn or a scar take a patient for corneal transplantation. So probably it will be worth comparing these with the normative data in a patient to see how the scar modulation works. The other cohort has to be a normative data of these patients when you're comparing the AIOS pictures, especially.
Absolutely, ma'am. So one thing about losartan drops, because that is an off-label use, and what a lot of people have been trying is you can use it 2 ways. You can use it either for prevention of scar in PRK haze patients, but if you have a post-infection scar or a post-chemical injury scar, or you have a scar because of post-PRK which is not resolving beyond 6 months to 1 year, that's when you start losartan.
Yeah.
You don't start losartan right away.
Yeah, I think that's the take-home message from her talk, that probably after 3 to 6 months, if you are
I
not
wanted
seeing
to
it,
ask
probably
that
that
only
is
at
the
what
drug to
stage.
go
Yes,
for.
ma'am.
Thanks,
Thank you.
Pooja, for a fantastic
One comment,
talk.
Pooja, just yeah. So, what about the vascularized scar? In the eyes which have, say, for example, a HSV keratitis, you have a large blood vessel often coming, and whatever studies we have seen about mice and therapy for fine needle diathermy, where once you occlude the blood vessel, what has been noted is the scar shrinks on its own. Okay, so now when we are like you elucidated that slide where you have looked at the various other factors which are responsible. So do you think therapies like losartan can go in conjunction with such therapies, whereas you do a fine needle diathermy and also use, are those my question is that are those HSV kind of scars or the ones with the vascularized scars also a candidate for losartan therapy?
I would say
Sorry.
yes, but it has to be a conjunct therapy, as you mentioned, because you have to treat the root cause first, and then because of the root cause there is a scar, you need adjuvant therapy to reduce the scar. So if there is a neovascularization, mice is something which
Yeah.
we saw in World Cornea Congress,
Yes.
which is catching up. I think that would be one of the treatment modality, but when you use mice like of a treatment, we've not had personal experience. The neovascularization reduces some amount of scarring, but not entirely. So I think
Yes.
you have to use losartan or maybe one of these anti-scarring drops, TGF beta driven drops along with a
Yes.
mice therapy.
So
It's an adjunct therapy, it's never
Yes.
one thing.
Thank
And you
you.
also have to personalize. Like you saw that scar can be because of various pathologies. So you have to, losartan is not going to work for all the patients, but specific ones.
Yes. Thank you.
It's not related to the chemical injury. It's if you have got basically a congenital limbal dermite, which is involving the visual axis, and the treatment modality is a surgical, which is both visual and cosmetic. And the various modalities are lamellar autograft, stem cell graft, abdominal graft, and the latest is smile lenticule tattooing. Does these drops have a role to reduce the caudal scarring? I have seen some cases of Gold-Hara syndrome, where there's a congenital limbal dermite with associated preauricular skin tag appendage and others. The question is that if you've got a grade 1 limbal dermite, you have to do observation and counseling. But if the limbal dermite involves the visual axis to threaten the vision, does these drops have, because when you excise the limbal dermite, there is a scarring. Then you tattoo it, then you put a caudal lenticule. Does these drops have a role in that?
So no personal experience. Based on the pathogenesis of how the drugs work, yes, but we will have to look into this.
Actually, in connection with this, Pooja, I wanted to ask you also.
Yes, ma'am.
You partially answered it, but at what stage of the scar formation that you would advise these drops? So, like what sir is mentioning, will the drug act at established scars, or will it act at newer scars which is just forming? If you have a scar, say 10-15 years old scar, will it work on these scars?
No,
So,
ma'am. So
at
these
what
are
stage will it work?
recently established scars, which are within probably 1 year, this drops will work well. But if it's a 10 or 15-year-old scar, like how sir is saying, it may not work because this drop works on cutting down your myofibroblast and fibroblast activity, and which is within 1 year of your scar formation. But long term, this drug has not known to have its use, but again, we have to use it on a larger scale to see
They
if
say
it will
that
work or not.
when you excite the limbal dermite, which involves visual axis, to get that, sort of cosmetic, you do a tattoo, and then you put a caudal lenticule upon it. This modality of surgery is thought to be a better option because post-operative astigmatism and the pain is less because don't put any sutures. Over the past about 8 years, I have seen about 8 cases of Gold-Hara syndrome, and I'm a little bit of
Yeah. I think in the interest of time, we'll move on to the next talk. This is a very exciting discussion. Thank you, Dr.
Thank
Pooja.
you, thank you.
We'd like, is Dr. Amit Pujara here? Dr. Amit? Okay, so in his absence, we'll move on to Dr. Rashmi Deshmukh, who's going to talk to us about Xenia implants, the next generation in ocular implants.
So Rashmi is working in the cornea department at LV Prasad Eye Institute, and she has done fantastic work on Xenia implants. Let's see what she has for us. This is for keratoconus, I guess. Yeah.
If Dr. Ashish is here, he can be ready. But yeah, thanks.
Yeah. At the outset, I would like to thank Dr. Rohit sir and Pooja for involving me in this session. So I'm going to be talking about Xenia implants, which are the new ocular implants used in advanced keratoconus. So traditionally, the management of keratoconus includes looking at the pachymetry. If the pachymetry is more than 400 microns, then we go ahead with cross-linking to halt the progression of keratoconus. And sometimes we combine it with intracorneal ring segments or PRK to regularize the cornea to manage the vision. But when the keratoconus is more advanced, then we either go for contact lenses. In case the vision is not improving, then we go ahead with keratoplasty. And that is where volume addition techniques are in play now and are being explored. So human lenticules and including smile lenticules and donor corneal lenticules have been explored for stromal addition keratoplasty in keratoconus. However, there is a global shortage of donor corneas, and this was more prominent during the pandemics when it was difficult to get human donor corneas. A global survey in 2012 also showed that more than half of the world's population has no access to corneal transplant tissue at the moment, and for almost every 70 needed corneas, only one is available. So that is where the role of xenotransplants comes into play. And why looking at porcine collagen corneas is because porcine corneas are anatomically and physiologically most similar to human cornea. And there's a Bowman's layer also, so it is biomechanically as strong as a human cornea would be, as opposed to rabbit corneas where Bowman's layer is absent. Then what is Xenia lenticule? So Xenia lenticule is one such implant for xenotransplantation which is made of porcine collagen. It is derived from the anterior corneal stroma using a 4-step process. And essentially it is free of cells and any antigenic remnants, so it makes the chances of rejection a little lower. This implant is, once it is derived from the anterior porcine cornea, it is further cross-linked with ultraviolet light multiple times to make it a hyper-cross-linked and a stiff lenticule. Currently, it is available in 90 to 100 microns thickness and in a 7 to 8 millimeters diameter in a disc fashion. So these were the 4 steps. Initially, the porcine corneal collagen lenticule is derived, then it is decellularized, and all the keratocytes and epitopes and antigens are washed away. Once you have the purified corneal extracellular matrix, then it undergoes collagen cross-linking to improve the biomechanical stiffness. The way it is inserted is that a femtosecond laser-assisted stromal pocket is created, and then the lenticule is inserted into the pocket and then unfolded and centered. So this was a part of a multi-center prospective open-label clinical trial. Sample size of 8 was sufficient to achieve the endpoints at our center. So we included all the patients more than 18 years of age with advanced keratoconus who were not suitable for collagen cross-linking, central corneal thickness of more than 350 microns, and contact lens intolerant patients were chosen. Patients with previous ocular surgeries, corneal scars, neurotrophic corneas, and having poor ocular surface were excluded. Also, corneal thickness less than 350 microns, and patients who were pregnant and lactating mothers were also excluded. So all the patients were subjected to slit lamp evaluation, corneal topography, confocal microscopy, and corneal OCT to look at the position of the implant. This is one of the examples of an OCT image of the implant placed in the anterior stroma. This was placed at 140 microns in a femtosecond laser-assisted stromal pocket. And this is the significant flattening that we were observing. This is over a period of 1 year. These are the slit lamp images where we see that at 1 month post-op, the lenticule is nice and clear. Towards more than 6 months, we can see that the central part of the cornea is clear, but there's a slight amount of haze towards the periphery which starts to appear. But the central cornea is clear. Looking at the results, the uncorrected and the best corrected visual acuity was statistically improved at 1 year. Even the keratometric flattening was significant at 6 months as well as 1 year. We could see a significant increase in pachymetry, and anterior corneal astigmatism also reduced at 1 year. We did not see a significant change in the posterior corneal astigmatism, but that could be because the implant itself was placed in the anterior cornea and did not have a significant effect on the posterior corneal curvature. We were able to recently publish this in the Journal of Refractive Surgery, these results. And like we see that we started with 9 patients, but we ended up following up only 7 patients at 1 year. This was because in 2 patients we had adverse events where we saw that just anterior to the lenticule, the anterior corneal stroma had melt. And we had to explant these lenticules. Looking at the figure of the histopathological image, we saw that the lenticules were still acellular when we removed them. There was no immigration of the keratocytes or corneal nerve fiber plexus within the lenticule. So similar experience was reported by another group of authors where they also saw early sterile keratolysis as a complication of porcine implants. The hypothesis that was suggested was that it could be an immune response to the implant or a response to the toxic compounds which are used in the decellularization or the chemical cross-linking process. During our discussions with the biomedical team of the company, we also came up with a hypothesis that that could be a mechanical stress exerted by this implant because it's quite stiff. So there could be a mismatch of the stiffness of the decellularized reticule and the recipient keratoconic cornea. So based on that, we decided to go a little deeper, and this is the follow-up result up to 3 months, when the lenticules are now being implanted at 220 to 240 microns depth. We are seeing that the uncorrected and the best corrected visual acuity is improved at 1 month, but it is not statistically significant at 3 months. Keratometric flattening is continuing to improve. We are seeing an improvement in the corneal pachymetry, but again, astigmatism was significantly improved at 1 month, not at 3 months. We are still following up these patients, and we are still trying to see whether they are continuing to improve or if there is any haze in the interface or if there are any stromal melts. This is the OCT image of a patient where the implant is placed a little deeper. And this is how the interface is looking at 3 months. Again, the central cornea is clear, but we can see that there's a slight amount of haze towards the periphery. So to summarize, porcine collagen implants do successfully improve the visual outcomes in these patients. These are cross-linked lenticules and supposed to have better biomechanics. They cause improvement in corneal curvature and are good for volume replacement as well, and could prove to be a novel alternative to human corneal tissue. But the technique still needs to be refined further to make the implant more biocompatible and to see why these adverse events were occurring in these particular patients. Thank you.
Thank you, Dr. Rashmi.
Thank you, Rashmi. Very nice innovation to use porcine instead of the human. I had a question for the 2 patients in which you saw the melt. Did you have any other surface-related issues? We know VKC is very closely related to, progressive keratoconus. So do you think that could have been one of the reasons?
So patients with any kind of ocular surface disorders were not included in this series at all. All these patients had healthy ocular surface to begin with. And the interesting thing that we were seeing was that all both the patients who had sterile melts, they appeared after 3 months. So before that, the ocular surface and everything was fine. Patients were still on topical steroids. But after around 3 months is when we are seeing the melt, and it is just anterior to the cornea. So we were, to the lenticule, I mean. We were also thinking whether it is affecting the nutrition above the lenticule of the corneal stroma. That could be one of the hypotheses that we were coming about. No history of severe eye rubbing, no history of allergic conjunctivitis. Sorry? We have not done any systemic evaluation of these patients to exclude any medical associations. We don't routinely do that, but yeah, might have a role.
Atopic dermatitis, ichthyosis.
Yeah, we don't routinely screen for Ehlers-Danlos unless we are seeing other features. Same with mitral valve prolapse as well.
Did you exclude osteogenesis imperfecta?
No, we didn't see any features to exclude osteogenesis imperfecta.
I don't mean that. Whenever you have got a keratoconus patients.
Yeah.
Keratoconjunctiva, VKH, and retinoid pigmentosa are important. Severe rubbing is a very important cause.
Yes.
And spricta. The thing is that you have to see the genetic also. The families have to be actually, close relations have to also screen for keratoconus. Number 2. I have seen a case when I was in the Middle East. There is a case of achondroplasia associated with bilateral keratoconus. Achondroplasia associated with bilateral keratoconus. Reported in Saudi Medical Journal, a very rare case. These patients are short, frontal bossing. normal intelligence and valid protocols. One case in the literature, probably in meatless of reported.
Yes, thankfully we didn't have any of those kind of systemic features in our patients, but thank you.
Rashmi, one question. Do you see a difference in the visual outcome between cones which are central and decentered cone? And do you kind of you just center the implant based on the center of the cornea, or do you make a change in the
So centering the implant on the cone was one of the things that we are looking at in the future series. But when the multicentric trial started, it was supposed to be implanted on the pupil center only. So this result that I'm showing is based on central cornea. It is not centered on the cone. But at the same time, among all those patients that we have done, only one had a decentered cone and rest of them had central cones only. This was just by chance. This was not that we had selected those kind of patients.
So would you like to change your inclusion criteria in the future based on whether cone is central or decentered?
In the future, the thing that we want to try is, does it make a difference when you are actually centering it on the cone instead of on the central cornea? And then looking at those results, we would see whether we want to change the procedure or not.
Yeah,
thank you, Dr. Rashmi.
Thank you.
Dr. Rashmi, just a few questions, just one or two questions.
Yeah, hi, Dr.
Would you still go with xenografts rather than smile grafts?
I would say at the moment it still needs to be improvised further, because until we find out why these adverse events are happening, we should not directly go ahead and start implanting it in every case. And we are implanting smile lenticules also in advanced keratoconus. Till now we are not seeing those kind of medicine using human lenticules, so we are continuing to do that.
Is it your preferred choice now to put deeper?
Sorry?
At a deeper layer, you said no 240 microns.
So we have only 3 months follow-up at the moment. I think longer follow-up is required because we've recently started putting it deeper.
And you don't have any cases which has progressed to...
Or they have not progressed, thankfully.
Thank you. We'll have our next speaker, Dr. Ashish, who's going to share his experience with virtual reality simulator for cataract surgical training.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Rohit Shetty and APAO AIOC committee for having me here and talking on this. Just trying to change gears, we've spoken about corneal scars and some corneal implants. This is something different. We are talking about virtual reality simulators for cataract surgical training. How does it enhance your surgical skills? Let's talk about the traditional training where most of the residents are trained on wet lab, and whether it's porcine eyes or goat eyes, the tissue is different. There is insufficient surgical training. Apart from that, there is fewer than that hands-on experience. The teaching is not standardized, and some of us do have a longer learning curve. And there is a risk to the patient if the trainees are not adequately treated. To top to that, it was also the impact of COVID-19, especially in countries like India, where it was impacted. Training opportunities were less. This thereby increased risk to the patients because the trainee was operating after a much longer time with less experience in wet labs because of less availability of tissues. This in turn led to lesser confident surgeons, and when there are lesser confident surgeons, the increasing backlog, especially in developing countries like ours, was increasing. So how does simulation or simulation-based training bridge this gap when there is a more backlog, we need to train more people within a speculated time frame? We all know that simulation models, whether they're augmented reality or virtual reality, have been shown to reduce complications in most of the specialties, more so in ophthalmology over this decade, where it has improved a lot. Video-based training modalities have been accepted in recent years, and they are also as effective, but though not very effective as compared to the virtual reality or the augmented reality platforms. In addition, latest developments where the simulators have improved, there are haptics which give real life-like sensations. When you touch the tissue, it feels exactly like the conjunctiva or sclera. It feels exactly like you're dissecting a tunnel. So that's where the haptic feedback system comes into picture, augmented by instructors who help you know how to take this simulation-based training. So there are many simulators. I'm in particular talking about the Help Me See simulator, which is the extremely high fidelity 3D virtual reality simulator, which brings what it brings to the table is it gives you a real life-like feedback. When I say that, there are handpieces wherein you can select any instrument that you like, select any step in any surgery that you want, whether it's phacoemulsification or SICS or even complications management like anterior vitrectomy. So each handpiece you will be able to select the instrument that you like, whether it's 23 gauge or 25 gauge trocar insertion for anterior vitrectomy and things like that. There is a side screen which helps you know which step you are doing, and you can do it multiple times, maybe 50, 60 times a day in a training environment. So the dictum here is practice until you cannot do it wrong. This is possible only because of the feedback by the haptics, which you just saw in the previous slide, which gives you the simulation intuition feeling, and it has these advantages that it is superior to the training in the goat side because the issue of availability is there, which is different. There is a difference in feel of the tissue every time you use a different tissue in the wet lab. You can do repeated practice. As I said, you can do almost 80, 100 times in a day a capsular access, and you can't get it wrong, which is augmented by standardized stitching. But most importantly, there is no risk to any human tissue that is used during the surgical process. So it's completely augmented reality. The students learn better handling of tissues even before they do their first surgery in the OR. So that's what simulation-based training brings to the table. The flagship training that is going on right now, which we are a part of, is the SICS model, which has been developed long back, and it is taught worldwide. Whether you want to do a tunnel dissection, there are training tools and guidelines which tell you exactly in what depth of the tissue you are. If there is a complication, you can go back and redo it. So in each training environment, each of these steps are done multiple times so that you know exactly where you are in your training methodology. In addition to that, there are self-study materials, instructors, dry lab activities, and sessions like debrief sessions which help the trainee understand where they are in their journey of simulation-based training. In addition to SICS, we also have courses like pars plana vitrectomy, anterior vitrectomy, PCR management, and suturing, and phacoemulsification. So for this this session, we thought we'll portray what we have on the phacoemulsification simulation-based training platform. Right from beginning the step of paracentesis to visco implantation to making a rexis, whether you're using a cystitome or a utrata, the simulator supports that. The guidelines or the images that you see are available on demand. So as you keep going ahead, you can take off these guidelines and continue the surgery like you do in a real life environment. It will also show you premature entry. It will also show damage to the cornea or the endothelium or even zonular dialysis. So this is what simulator brings to the table. Now this has been possible because of the efforts of a team of subject matter experts who actually sit down and tell what should cause this complication, what should cause this amount of zonular breakage. It's an iterative process, and because of this iterative process, the simulation-based platform gets enhanced every time. So right from hydrodissection to the steps like phacoemulsification, getting the trench in the nucleotomy at what dissection depth you are, seeing the foot pedal or the guidelines that you see is going to help. It is already helping students worldwide to know exactly what step should be done to get the depth of dissection right, to get the plane of dissection right, and even to have the separation correctly. So that's where this haptic feedback simulation-based training brings to the table. Now, when we say that, we also say that this is validated. Recent publication, which came in Scientific Reports in October 24, says that yes, this phacoemulsification module on this system is actually validated, and it helps trainee gain better experience and can be replicated worldwide across systems to have the same amount of training worldwide. So the phacoemulsification training that is present on the Help Me See system is actually having a validation effect. How effective we are, we actually did a randomized study where we divided trainees into two groups. One underwent simulation-based training, followed by mentored live surgical training transition. The other did traditional wet lab, and we had these trainees from institutes like LV Prasad, Arvind, Mahatma Eye Hospital, and then we compared the results, and to our knowledge, we saw that the group that did simulation-based training had at least 40% less complications, reduced learning curve, and higher confidence when they went into the OR to do the first live surgery. So yes, it is effective. Yes, the system is validated. Also, if you look at what are the virtual reality platform simulations, what are they doing? So all comparatively, there is another article that was shared that patient safety assessment in OR should be the prime criteria in choosing any virtual reality simulation-based training platform, and this is where the Help Me See simulator also scored well. So in addition to training residents, it is also going to be useful for people who want to enhance their surgical skills when they want to learn something new. And that's where we also had a suture simulator where passing the suture through a correct depth, tying the knot, burying the suture, cutting it, and all that is also possible. And this has also been recently presented at a meeting at AO. So the take-home message, what I would like to share from our experience is that simulation-based training enhances skills and reduces complications. This in turn gives better outcomes to the patient. You can do more surgeries because the surgical time and the table time of the trainee and the attendee is reduced. It has been incorporated rightfully, and this is coming from places like Arvind, LV Prasad, Shankara, where they have the simulator going, which is incorporated into the residency training programs. So this definitely is a game changer, which everybody wants. At the end, should lead to a happy surgeon, happy trainer, and happy patient outcome. I thank you for your attention.
Thank you, Dr. Ashish. Would you say there's a learning curve in using the simulator itself, and what do you think is the minimum duration, because everyone doesn't learn at the same pace, so what would be the minimum duration they have to use the simulator?
There is a learning curve, you're right, especially to getting used to the simulator, but that learning curve from anybody would be around 15-20 minutes to get used to the environment of the simulator. Having said that, yes, this learning curve is also incorporated into the training program, so that the stages that you go into the training program are met with. So yes, learning curve is there, but it is just one module, 15-20 minutes, and you're good to go for the rest of the training system.
Is there a stipulated time? How many hours the PGs, postgraduates?
So traditionally, our high-end courses like the SICS or the PIC are a 5-day course where at least you spend 6 hours per day on the simulator. Say a step like capsular excess or a nucleus dislocation or a nucleotomy on PECO, you would do at least 150-200 attempts in a day. You will continue practicing that separately versus in a continuous mode, so that you can go from first step to the last step as well as you progress on to the training. So yes, there is more emphasis on the time spent by the trainee on the simulator, aided by an instructor who will guide you through the process.
Thank you, sir. How much is the cost for this thing?
So there is a cost to it. In India, it's pretty subsidized, around 25,000-30,000 for the course, which is 1 week's time.
For the instrument as such, to buy from a medical college point of view?
We don't plan to sell it. There is a lease model. So we lease it to you depending on how many number of trainees you can support in a year. So that's the contribution.
Thank you, sir.
Thank you very much.
Do you have any grading system to grade the postgraduate students while using the simulator?
Yes. So there is a subjective and an objective grading system. The simulator has a page called performance parameters where, say for example, your scleral growth should be between so and so. If you do less, your marks go down, the score comes down, and if you get it correct, the score is up. So there is an objective scoring system on the simulator. In addition, there is a subjective. We also use the ICO scoring system to grade them. So we use both of them, ICO Sim Oscar and ICO Oscar, as well as this grading system on the simulator.
Does it reduce the number of cases they do in the wet lab there, on the either animal model, or from the simulator they are going straight to the human eyes?
From the simulator, they go to the mentored life surgeries with an attendee surgeon with them, which with the study that we did, that those surgeries required pretty less as compared to somebody who did not do simulation-based training.
Does this have the potential to replace the goat eye based wet lab, which has been going on? What do you look at?
The idea is to not replace anything that is already there in the training world. The idea is to augment what is available, in the hope that the outcomes are better on the end result of the patient. If it is augmenting something, it's good, but replacing something is not the idea yet.
Thank you.
Thank you.
Call our next speaker, Dr. Tirumalesh, who's going to share his experiences on an innovative surgical experience for failed macular holes.
That was 10 years ago. No, it's 1 crore. No, 1 crore it was that time. This became close anterior and posterior. You did. We did. Rohit is very possessive about it. Step-by-step surgery, as early as possible. don't get course, I feel.
I'd like to thank Dr. Rohit, AIOS, and the APO for this opportunity. My slides, please. I would also like to acknowledge the team that participated. So, thank you. So I would also like to acknowledge the team that participated in this. Apart from me, we also have our lab colleagues who had helped in looking into the science of it. We all know that macular hole surgery, especially the failed ones, are a difficult challenge, and this is the patient that I would like to discuss. This patient had a macular hole along with the retinal detachment. In the initial surgery, the ILM was peeled. So what we did in this particular case was when we went in, we found that the SOR was already done. So this patient had a PVR that was setting in. So we initially dissected the PVR and removed from the periphery so that the retina is amenable for settlement. So I had two options. Either I settle the retinal detachment first and then cut a little retina, use a retinal autograft and close it. Based on our work on the ILM and glia, what I thought this time was that we could harvest the peripheral vitreous and we will use the peripheral vitreous as a plug. So here you can see that I am first debulking the vitreous. I did a fluid air exchange. Harvesting the hyaloid is a little tricky situation. So one can dehydrate the vitreous under air and select the area which is amenable. So here you can see me doing the fluid air exchange. And then the vitreous base is held in using a bimanual technique using a forceps. Then I harvested the hyaloid. So once I harvested the hyaloid, it took a couple of attempts, and then you can see that it's a clear hyaloid tissue. So once the hyaloid tissue was harvested, I used part of it because it was too large, and I kind of sent one part of the lab. Then I did the laser, allowed the hyaloid to dehydrate a little more on the spatula. So once I finished my laser, what I did next was it's important to do the anti-laser as well. Now you can see that I'm using the spatula to take that hyaloid that I harvested. The first thing that I did was I dropped it over the optic disc first, and then I used the green tip to hold it, and then I used the back fresh part of it to put it over the hole. So once this was achieved, the rest of the fluid air exchange was done, and then I exchanged it for oil. You can see the hyaloid being overlaid onto the hole. I don't tuck it, I just overlaid on it, and then I topped it with oil. Now, this is the post-op result. You can see on day one that you can see the hyaloid plug which is there, and as the days went forward, there was proliferation of the glia which kind of closed. So what makes me tell you that there is glia there here is based on this, that these are the post-op images. So what we did was we took the hyaloid, one part we cultured, the other part we looked into the hyaloid, and we would see there are certain hyaloid-derived cells which are there. Now, to identify the cells, what we did was we used a DAPI staining and we also used immunofluorescent imaging. So we stained it with GFAP, and you can see that the glial cells are there in the harvested peripheral vitreous. So it was not the hyaloid which kind of closed the hole, but these cells which were there in the matrix of the hyaloid that helped in closure of the hole. Now, this is a phase contrast microscopy where you can see ARPE cells, and the ARPE cells don't secrete SMA. So the next question is, if the glia proliferated, how did the two edges of the hole come together and how did the glia disappear? So what makes the glial cells proliferate? Now, you can see that in our harvested cells, the alpha SMA is positive, which means that the glia which bridged then contracted and brought them together and exited out once the healing was complete. Now, we were not the first ones to say that there are glial cells present in the anterior hyaloid phase. This particular paper actually indicated that these are mesodermal derived cells which are present in the posterior hyaloid in the retina. So this is part of the immune system or the innate immune system part, which can be used for healing. Now, before we did this, we had harvested ILM in our routine macular hole cases, and we also found glia which is present in the peeled ILM. So this was the background knowledge based on which we used this particular technique. Now, many people ask if there is glia present on the ILM, why don't we normally see it in a macular hole case? That is because we are imaging under gas. But if you put oil and serially image those patients, you can see that in day 1 there is glial proliferation. As the days progress, this glia tends to first remodel, and once by the end of 1 month or 6 weeks, you can see that the glial elimination has started, and once you see the patient at 3 to 6 months, the glia is not there. So this serially kind of demonstrates that glia is there and it can really bridge the hole, and it is actually the glia that closes hole. Surgery is an art where you're trying to put the two edges together, but what cements and keeps the retina bridged together is glial proliferation and glial remodeling. Now, this particular this thing was we grew the glia, and what dot-like cells which are there actually had processes that you can see across when subjected to phase contrast and immunofluorescent microscopy. Thank you very much.
Very innovative idea and thinking out of the box, and theoretically speaking, it definitely sounds nice that you put this hyaloid and you expect the cells to proliferate and grow. But that is what actually happens when we put the fibrin glue, or say any other tissue for that matter, like amniotic membrane, or some people have even advocated using the anterior lens capsule, using the epiretinal membrane, and so many things. So I think the idea is that you just bridge the anatomical gap, and then you allow the cells to grow.
Are also part of
Yeah.
there in the retina as well.
Yeah.
Not that the hyaloid brought the glia.
Yeah.
What I'm trying to say is that there is also glia present in the posterior hyaloid network based on what I showed on the slides. The glia that we harvested, we examined, we found it.
Yeah.
And we grew the glia from the harvested hyaloid. I'm not saying that I was able to hold the cells from there and I'm putting it there. No, that's not my the reasoning at all. What I'm saying is, if I take a bit of retinal tissue and if I grow it, the neuronal tissues are going to degenerate, but the glia, which is the resident repair tissue, has the only cell which can actually proliferate if you grow the retina. That's the concept that we're trying to
True, I agree that. Another thing is that I think the amount of hyaloid that you put there, because we obviously know that if you put too much of vitreous there, it's going to contract, and then that is going to have much more problems, like they may develop into epiretinal membranes and then can cause traction, and you might end up in fact having a worse outcome than so probably the amount of hyaloid which you put might be a crucial point in this.
Absolutely.
Yeah.
So it should be proportional to the whole, and just probably 10% greater than that, so that it is acting as a network where the cells that are going to migrate are going to come and stay, because it's the matrix that is required for this tissue to proliferate, rather than putting it too large over it, like you rightly said. It can produce those kind of complications. Thank you.
Thirumilesh, do you use silicone oil so that you can get serial OCTs?
Not really. The patient had a redetachment. He had got the surgery done elsewhere. They removed the oil, and this particular patient developed a redetachment after 6 weeks. So the patient also had peripheral PVR, and I usually do not use gas in patients where there is peripheral anterior PVR.
Thank you, Dr. Tirumalesh, for that innovative approach. Final speaker in this session will be Dr. Manjunath, who's going to talk about the Manmara chopper, a novel innovation that he's been part of. Is Dr. Vineet Joshi here? No. Two people absent, we're just about making the time.
There's a lot of discussion in the middle by that gentleman.
Clearly. He seemed like
Good afternoon, everybody. I would like to thank Dr. Rohit Shetty and APAO and AIOS for giving me this opportunity to talk on the Manmara chopper, which is used in the phacoemulsification cataract surgery. See, what is the thought process? See, in the phaco cataract surgery, by reducing the ultrasound energy, by pre-chopping the nucleus without use of ultrasound energy, so you're going to cause a healthier endothelium and early visual recovery and clear cornea next post-operative day. And the turbulence in the antechamber is reduced by pre-chopping the nucleus. When you are doing any trenching like divide and conquer or stop and chop or direct chop, you are causing more turbulence in the antechamber, which is responsible for the release of inflammatory markers like VEGF, TNF-alpha and IL-6, which are responsible for the progression of diabetic retinopathy or development of macular edema. This is an animation video showing how the pre-chopping is done. 2.8 millimeter main port is done, 3 clock hours away side port is done, 5.5 millimeter axis. After doing it, the second sustainer goes to the side port and the chopper goes to the main port and divides the nucleus into two halves. So by rotating it 90 degrees, we have ultimately having 4 quadrants. Showing a video of pre-chopping. Excuse me, sorry. See, on the right side, what you see is the chopper, which is 1 millimeter in diameter and 2 millimeters in the length, and the front cutting edge and the posterior aspect is round and the bottom is rounded like boat shape. On the left side, what you see is the sustainer, which is 2 millimeters in length with a ball tip and inner cutting edge. So sustainer goes through the side port and the chopper goes through the main port. .8 millimeter main port is done. 3 clock hours away, 2 side ports are done. Under the anticapsule is stained by using trypan blue. Excess trypan blue is washed off. Antechamber is filled up with viscoelastic. 5 to 5.5 millimeter axis is fashioned using cystitome. Then the hydrodissection is done to separate the nucleus from the cortex. Antechamber is filled up with viscoelastic. See, now I am going to get the sustainer in the left hand and the chopper in the main port. Sustainer goes through the underneath the rexis margin, hooks onto the opposite equator. Chopper goes through the main wound. Just in front of the rexis margin, both the instruments are brought together and it's divided into two equal halves. Without using ultrasound energy, we are cutting the nucleus into 4 quadrants. Each heminucleus is rotated by 90 degrees and subdivided further. And the heminucleus is rotated 180 degrees. this heminucleus is divided into two halves. So now we have 4 quadrants. Without using the ultrasound energy, we have divided the nucleus into 4 quadrants. And now we go with the quadrant mode through the phaco tip, and each quadrant is picked up and brought into central 3 mm zone and emulsified in the bag. So by this technique, we are almost reducing the ultrasound energy from 50 to 60%. In the conventional mode, what you are going to do is either you do divide and conquer, or stop and chop, or direct chop. So in that amount of laser energy saved by avoiding that step will help us to help the patient to get a early visual recovery and less endothelial cell loss, and the turbulence which is caused in the AC by doing trenching or direct chop or stop and chop is minimized, which in turn will reduce the release of inflammatory markers in the antechamber, which are responsible for the progression of macular edema or progression of diabetic retinopathy in diabetic patients. So hence we are avoiding all the unwanted complications. So the last bit is emulsified now. And this can be safely done from grade 2 to grade 3 cataract. Beyond grade 3 cataract, I don't recommend this technique. And the rest of the cortical matter is aspirated. You can see the wound is very clear. Under the hydroimplantation of the intraocular lens. I'll be showing 2 more surgical videos just to show the pre-chopping in mature cataract and hard cataracts. See, this is a mature cataract, but not a hard cataract, but it is soft cataract. The sustainer goes through the side port, goes underneath the rexis margin, hooks onto the opposite equator. This chopper goes through the main port just in front of the rexis margin. You bisect the nucleus, divide it into 2 halves. So you have 2 heminuclei now. Each heminuclei is rotated by 90 degrees and subdivided into another 2 halves. And this heminucleus is rotated 180 degrees and bisected into 2 halves. So you have 4 quadrants of this nucleus, and in the back I am dividing the nucleus. And now go with the phaco probe and pick up each quadrant and emulsify it at the central 3 mm zone. And this is a hard cataract. The similar technique is followed. This is almost grade 3 to grade 4 cataract. The nucleus is bisected. And on the right side, what you see is the animated video. And the heminucleus is rotated by 90 degrees, and that is bisected again. So we have 4 quadrants now. Thank you everyone for patient listening, and open the floor for questions, please.
Is this available commercially? Can somebody procure this?
This? I've been doing it for the last 1 year, and we have a company there. You can purchase from there.
In small rexes, what is your recommendation? Do you go ahead and do it, or do you increase the rexis size?
Ideal size of the rexis should be at least 5 mm. Less than the 5 mm rexis, the chances of zonular diasis is very high. So anywhere between 5 to 5.5 mm rexis is ideal case for pre-chopping the nucleus.
How many cases do you recommend before we start this procedure for training purpose?
Yeah, it's not for a beginner surgeon. You have to be well versed with your horizontal chop techniques. So a person who has done more than 1,000 surgeries can easily adopt this technique, and the learning curve is not very steep, and a person can learn with 20 or 30 surgeries, he'll be able to master this technique.
Thank you.
If we have no more questions, we'll end this session on time. Thank you very much on behalf.
Thank you so much for patiently listening.
Just to make sure that Dr. Amit Pujara is not here. Right. Okay. Thank you so much. Can we just request everyone?